Hi, I'm Dr. Jennifer Hanna. This is a talk on Zollinger Ellison syndrome. The learning objectives are to 1. Learn the clinical syndrome associated with ZES, 2. Learn the radiographic findings associated with ZES, learn how to make the diagnosis of ZES, and learn the medical and surgical treatment options for patients diagnosed with ZES. This is an outline of the talk. Patients with Zollinger Ellison syndrome have gastrin-secreting tumors and the associated clinical consequences. This disorder can occur sporadically or as a manifestation of multiple endocrine neoplasia type 1, or MEN type 1. Approximately 80% of patients have the sporadic form, although acquired mutations in the MEN1 gene are observed commonly in sporadic gastrinomas. Medical therapy is the current standard of care for most patients with ZES as a part of the MEN1 syndrome. This consists of using acid suppression therapy, including H2 antagonists and the more powerful hydrogen-potassium ATPase antagonists, also known as proton pump inhibitors. By contrast, many patients with sporadic ZES are candidates for surgical therapy. Prior to the development of effective acid suppression therapy, the major morbidity and mortality of ZES were related to complications of fulminant peptic ulcer disease, and total gastrectomy was the only effective measure to protect patients from these problems. The incidence in the United States ranges from 0.1 to 1% of patients with peptic ulcer disease. However, this may be an underestimation because patients with undiagnosed ZES often have symptoms similar to those caused by typical peptic ulcer disease related to H. pylori infection or nonsteroidal anti-inflammatory drugs. These symptoms may be controlled by standard doses of an anti-secretory drug, and the patients may not be tested for hypergastrinemia. Most patients are diagnosed between the ages of 20 and 50, but patients as young as 7 and as old as 90 have been identified. The male-to-female ratio is approximately 1.5 to 1. As many as 70% of gastrinomas form in the duodenum. The remainder, with rare exception, arise in the pancreas or less often in lymph nodes adjacent to the pancreas. Duodenal gastrinomas tend to be quite small and are often multiple. They have less malignant potential than the solitary sporadic pancreatic gastrinomas. Gastrinomas are delivered from enteroendocrine cells arising mainly in the pancreas, but also in the small intestine. Tumors that arise from these cells are considered neuroendocrine tumors. Histologically, most gastrinomas are well-differentiated neuroendocrine tumors with few mitoses and a histologic appearance that is similar to that of other pancreatic neuroendocrine tumors. As with other pancreatic neuroendocrine tumors, the degree of malignancy cannot be predicted by morphologic appearance alone. The cells produce abundant neurosecretory granules, with gastrin being the predominant peptide within the secretory granules of gastrinoma cells. The designation of the tumor as a gastrinoma is based upon the presence of a clinical syndrome that results from tumor production of gastrin, and not by its morphologic appearance or the presence of gastrin in the secretory granules. If a tumor stands for gastrin, but does not produce symptoms of the Zollinger Ellison syndrome, it should not be considered a gastrinoma. Excessive gastrin secretion from gastrinoma results in high gastric acid output for 2 reasons. 1. Gastrin has trophic action on parietal cells and histamine-secreting enterochromaffin-like cells, and gastrin stimulates parietal cells largely via the release of histamine. Over 90% of patients with Zollinger Ellison syndrome develop peptic ulcers. Patients with this syndrome, like those with sporadic peptic ulcer disease, often present with solitary ulcers less than 1 centimeter in diameter. 75% are in the first portion of the duodenum. The ulcers recur much more often than in patients with sporadic ulcer disease. Diarrhea can also be a predominant feature of ZES, secondary to the high rate of gastric acid secretion, resulting in a volume load that cannot be fully reabsorbed by the small intestine and colon. The picture on the left-hand side demonstrates a normal air contrast upper gastrointestinal study showing normal gastric folds and small intestinal anatomy and no masses. By contrast, the upper GI series on the right-hand side demonstrates 3 different sized ulcers in the wall of the stomach in a patient with intractable epigastric pain. The patient had a high fasting serum gastrin concentration consistent with Zollinger Ellison syndrome, and a small duodenal wall gastrinoma was identified at surgery. The presence or absence of clinical symptoms or signs at the initial assessment in 261 patients with Zollinger Ellison syndrome is displayed in the graph above. The most common presenting symptoms are abdominal pain, diarrhea, prominent gastric folds, and a confirmed peptic ulcer. Prominent gastric body folds, esophageal stricture, and pyloric or duodenal scarring were determined by upper gastrointestinal endoscopy. A confirmed peptic ulcer was assessed by upper gastrointestinal endoscopy or X-ray studies. Only a small number of patients with peptic ulcer disease have the Zollinger Ellison syndrome. Its presence should be suspected in patients with findings suggestive of acid hypersecretion, such as multiple or refractory ulcers or an ulcer location distal to the duodenum, diarrhea, or a personal or family history of MEN1. Predominantly, 2 laboratory tests are used for the diagnosis of ZES: fasting serum gastrin and the secretin stimulation test. Fasting serum gastrin should be measured in any patient suspected of having ZES. A value greater than 100,000 picograms per milliliter is virtually diagnostic of the disorder. Measurement of gastric pH on a single specimen is important to exclude secondary hypergastrinemia due to achlorhydria, such as in patients with pernicious anemia or atrophic gastritis, since the serum gastrin level can easily exceed 1,000 picograms per milliliter in these circumstances. Higher levels are more likely with pancreatic compared with duodenal tumors, large tumor size, and with metastatic disease. The secretin stimulation test can differentiate patients with gastrinomas from those with many other causes of hypergastrinemia and should be performed in every patient suspected to have ZES who has a non-diagnostic fasting serum gastrin concentration. Secretin stimulates the release of gastrin by gastrinoma cells, and therefore most patients with these tumors have a dramatic rise in serum gastrin in response to a secretin infusion. In contrast, normal gastric G cells are inhibited by secretin, and therefore serum gastrin concentrations do not rise in patients with other causes of hypergastrinemia. A positive test is defined by a rise in serum gastrin by 200 picograms per milliliter, or more within 20 minutes of secretin administration. PPIs can interfere with the test and should be discontinued for 1 week prior to secretin administration. After the diagnosis of ZES is made, the gastrinoma must be located and staged. The only exception is in patients in whom the decision has been made to treat medically, as for example in the MEN1 syndrome. The major modalities for tumor identification include the following. First, cross-sectional imaging with helical contrast-enhanced triple-phase CT and MRI can be used. Second, endoscopic ultrasound can be especially valuable in imaging sub-centimeter pancreatic neuroendocrine tumors and duodenal gastrinomas. In addition, it permits fine needle aspiration for histologic identification. Third, somatostatin receptor scintigraphy with labeled octreotide can be used and may be the most accurate in identifying primary gastrinomas. When strong clinical suspicion persists despite negative results, other techniques that can be used to localize the tumor include angiography and selective arterial stimulation and venous sample with calcium gluconate. Sometimes tumor localization can only be achieved at laparotomy by direct palpation, duodenal transillumination, or intraoperative ultrasound. We will now discuss the 2 current goals of therapy in ZES: control of the complications resulting from autonomous release of gastrin and control of the tumor itself. The goal of medical management in ZES is to limit the clinical manifestations and complications of peptic ulcer disease. Because peptic symptoms in patients with ZES are often a poor marker of acid secretion, formal acid secretory studies have been advocated to guide the dosage of acid suppressants, with the goal of reducing gastric acid secretion to below 10 milliequivalents per hour prior to the next dose. However, such studies are often not available even in major medical centers, and it has become customary among many gastroenterologists to initiate and maintain proton pump inhibitors at high dosage using symptoms alone as a signal to increase the dose. There have been few, if any, episodes of major peptic diathesis associated with this approach. The proton pump inhibitors are the first-line medical management for the treatment of ZES. These include omeprazole, lansoprazole, pantoprazole, and esomeprazole. Proton pump inhibitors effectively block acid secretion by irreversibly binding to and inhibiting the hydrogen-potassium ATPase that resides on the luminal surface of the parietal cell. Their effects last for more than 24 hours, and as a result, many patients can be treated with a once-a-day regimen. Patients with ZES should be started on a high dose of a PPI, for example, 60 milligrams daily of omeprazole. Some patients require an early upward titration of these doses. However, once control of acid output has been achieved, a gradual dose reduction is usually possible. While PPIs are unable to control gastric acid secretion, somatostatin analogs such as octreotide can inhibit secretion of gastrin. However, due to the unpredictability of the response, they are not first-line agents for symptomatic patients with hypergastrinemia. Patients with a sporadic gastrinoma who do not have evidence of metastatic spread of disease should be offered exploratory laparotomy and resection with curative intent. In contrast, laparotomy is not routinely recommended for patients with ZES or part of MEN1, since the multifocal nature of the tumors in this disorder almost uniformly precludes cure of gastrin hypersecretion. This recommendation is derived from the observation that in addition to eliminating or at least decreasing the need for anti-secretory medical therapy, successful resection of sporadic gastrinomas protects against the possibility of eventual morbidity and death from metastatic spread of the tumor. The likelihood for surgical cure is especially high for extrapancreatic gastrinomas. 80% of curable gastrinomas lie within the gastrinoma triangle, comprised of the parapancreatic lymph nodes at the head of the pancreas and the duodenal sweep. Gastrin secretion may not return to the normal range following gastrinoma secretion because of a residual excess of gastric parietal cells, a consequence of the trophic effect of chronically elevated gastrin levels. Up to 40% of patients will require prolonged anti-secretory therapy to control hyperacidity following curative resection, and such patients need continued monitoring for acid hypersecretion. A proximal gastric vagotomy performed at the time of tumor resection has been advocated to reduce and in some cases obviate the need for postoperative medical therapy, particularly when complete resection of the gastrinoma tissue cannot be accomplished. However, it is currently uncommonly performed because of the efficacy of proton pump inhibitors. There is limited evidence from which to make recommendations for follow-up after a resection of a gastrinoma. Guidelines from the National Comprehensive Cancer Network, based upon expert consensus, include the following recommendations for follow-up after resection. 3 and 6 months post-resection surveillance should involve a history and physical examination, serum gastrin, and computed tomography or magnetic resonance imaging. Long-term surveillance should include a history and physical examination with tumor markers every 6 to 12 months for years 1 to 3, and as clinically indicated thereafter. Imaging studies are recommended only as clinically indicated. Metastatic disease is evident at the time of diagnosis in approximately 1/3 of patients with a gastrinoma. The liver is the major metastatic site for gastrinomas. The second most common site is bone, almost all of which occur in patients who also have liver metastases. Somatostatin receptor scintigraphy and MRI are the best tests to detect these lesions. Metastatic gastrinoma is now the most common cause of morbidity and mortality in patients with ZES. Unfortunately, current treatment modalities are of limited benefit. Somatostatin analogs such as octreotide is highly effective in controlling symptoms associated with hormone hypersecretion and other pancreatic islet cell tumors that express somatostatin receptors such as glucagonomas and VIPomas, as well as carcinoid tumors. However, its efficacy is less predictable for gastrinomas. Nevertheless, octreotide can reduce gastrin levels and may slow tumor growth, but objective evidence of anti-tumor activity is rare. Therapies specifically for liver metastases include resection, hepatic artery embolization, RFA and cryoablation, and chemotherapy. Hepatic resection is indicated for the treatment of metastatic liver disease in the absence of diffuse bilobar involvement, comprised liver function, or extensive extrahepatic metastases. Although the majority of cases will not be cured by surgery, prolonged survival is often possible given the slow-growing nature of these tumors. Hepatic artery embolization with or without selective hepatic artery infusion of chemotherapy is frequently applied as a palliative technique in patients with symptomatic hepatic metastases who are not candidates for surgical resection. Liver metastases derive most of their blood supply from the hepatic artery, where healthy hepatocytes derive about 70% of their blood supply from the portal vein. This provides the rationale for therapeutic embolization of the hepatic artery with the goal of inducing necrosis of the metastases with minimal damage to normal liver parenchyma. Response rates as measured by decrease in hormonal secretion or by radiographic regression are generally over 50%. Other approaches to the treatment of hepatic predominant disease include radiofrequency ablation and cryoablation, either alone or in conjunction with surgical debulking. These techniques are applicable only to smaller lesions, and their long-term efficacy is uncertain. Experience with systemic chemotherapy for metastatic gastronoma is limited. The traditional regimen of choice has been streptozocin and doxorubicin, though anti-tumor activity has also been shown for regimens containing the orally active alkylating agent temozolomide. Response rates as high as 69% have been reported for metastatic islet cell tumors, defined by decrease in endocrine hyperfunction. These are summary algorithms for the diagnosis and treatment of Zollinger Ellison syndrome and metastatic gastronoma. Mortality from gastrinomas largely depends upon whether the tumor is benign or malignant and the extent of disease involvement. Patients with liver metastases had a 10-year survival of only 30% compared with a 15-year survival of 83% in those without liver metastases. Patients with MEN1 had a significantly lower rate of metastasis at the time of initial diagnosis. This rate was approximately 6%. Their high overall survival rate, which was 100% at 20 years, reflected this fact. The level of fasting serum gastrin at the time of initial diagnosis may provide an indication of disease extent and estimated prognosis in patients with sporadic ZES. In summary, patients with ZES have gastrin-secreting tumors with associated clinical consequences. ZES can occur sporadically or as a manifestation of MEN1. Medical therapy consisting of acid suppression is the standard of care for patients with ZES as part of the MEN1 syndrome. The goal of therapy in ZES is control of the complications resulting from autonomous release of gastrin, mainly peptic ulcer disease, as well as control of the tumor itself. The liver is the most common site of metastatic disease, and metastatic disease is the most common cause of morbidity and mortality in ZES. Thank you.